everyone. I'm the second year pediatric resident Kerem, and we have a medical student, Peyton. We will present topic of the month, allergy immunology, and welcome.
And Dr. Duran is.
And our, of course, sorry, our model expert is Dr. Duran, and she is working in Dakota Allergy Asthma Clinic as a allergy immunology specialist. And Dr. Bach also our model builder, and she is also our after build this modules. And thank you.
Can I say hi real quick?
Oh.
I just haven't met any of you. So my name's Rebecca Duran. I am not that far out of fellowship and residency, so it's pretty nostalgic and fun to be back here. Please ask questions and let me know what you guys want to know about this. It's such a small, I think everybody kind of knows this about AI. It's such a small field, but it's so fun. It's so fun, and proportionally, it's always a large part of steps, even if it's not what you actually see in the hospital and clinic and stuff. So I'm always happy to help. I'll put my email address and stuff up here too later on if you guys ever want to come to clinic or just ask questions. I am happy to assist.
And you can email me and I will connect you with her too
Yeah.
if you don't write it down today. Thanks, Kara.
And of course, I will start with allergy session. It will be a very quick session. Then Peyton will present the immunology section. Then we have a Jeopardy game, so a bit small competition. So hypersensitivity is the main reason why we have a allergy or immunologic diseases. If we have a hypersensitive reaction to our own cells, it causes autoimmune disease. If we have hypersensitive outside foreign bodies, it will cause the allergies. We have 4 types of hypersensitivity reaction: type 1 immediate reactions, type 2 cytotoxic reactions, type 3 immune complex reaction, and type 4 delayed reaction. And allergies, anaphylaxis, asthma, urticaria is type 1, and some autoimmune disease can be type 2, type 3, and atopic dermatitis, and poison ivy interaction, or UV is type 4 delayed hypersensitivity reaction. And first, I will start with type 1 reaction. There are 2 phases. One is acute response. It will happens when you expose to this hypersensitive reason. It will happen in minutes, and it causes vasodilation, and it will increase the permeability, and it will cause also bronchoconstriction. So when patient exposed to allergen, they have shortness of breath, and they will become flushed, and they will feel more tense on that situation. And we have a late phase response. Everyone can see it first phase, it will happen all of a sudden, and in a couple hours, allergy can be bounced back with this late phase response. And on this phase, we will see eosinophils and basophils release their cytokines, and it can cause another reaction. It can cause inflammation, tissue damage, and asthma hyperactivity reactions. And anaphylaxis, it's very important to diagnose anaphylaxis as a general pediatrician. For also it's very important. And we have 3 criteria. And first criteria is acute onset and involving of skin, mucosa, or respiratory system. Or it should be 2 systems affected, not just one. It can be skin, it can be respiratory, it can be cardiovascular or GI system. And also hypotension. Hypotension is another criteria. It can be vague, it's easy to miss if you don't check the blood pressure of the patients. And also patients can be collapse, and they can syncope with anaphylaxis. So when we see patient with syncope, always we should keep in mind that patient can anaphylaxis. Asthma is also related to type 1 hypersensitive reaction, and there is some asthma predictive index for children less than 3 years old. So as we know, as a pediatric residents, we can't diagnose asthma especially below 5 years of age. It's so hard because they can't comply the like this allergy test, like pulmonary function test. So we call it reactive airway disease, but it's actually reactive airway disease and asthma is almost like similar like diseases. And like if patient has a like patient has a like father or mother has a like asthma, they are on high risk, or like if they have another disease like allergic rhinitis, or like they have like wheezing on the cold, or they have eosinophilia on like CBC, this is also like a minor criteria. And asthma treatments, like we have like four step like treatments. Like we have like short acting, long acting, and also we have like inhaled corticosteroids. I will not deep dive. This is more like pulmonology section, and we have like a short time. But short acting beta beta agonist like albuterol is the most common medication we use in like asthma diseases. Also, we can use like inhaled corticosteroids. Also, we can add on therapy if they have like moderate to severe diseases. We can add like montelukast or other like biological agents. Allergic rhinitis also like we call it hay fever. It's like everyone like maybe like at least 10-15% of patients say they have like environmental allergy. It means like allergic rhinitis overall. And like when like they expose, it can cause like congestion. Also, there is like if on chronic exposures, they have like other symptoms. Like we can see like nasal salute and like crease here, and there's some like Denny Morgan lines here. On springtime, it's mostly caused by tree pollen. On summertime, it's grass, and fall wheat. So this order is important, like tree, grass, wheat in allergy, because we can differentiate like when patients come to clinic, like when they have symptoms, we can have some idea like what can be caused these symptoms. And for treatment, gold standard with intranasal corticosteroids, but they need to keep like used every day. Like this is the hardest part, and they should start earlier, like before symptoms. When they start with symptoms, it's like takes too much time, so it will not relieve in a like couple days. Atopic dermatitis, this is, as I said, this is like type 4 hypersensitivity reaction, and each rashes is its effect like different places. And for management, we can daily short baths, and can we apply moisturizer like aquaphor and like wet bath. Also, avoiding like sun exposure and avoiding the like irritants is very important. Urticaria and angioedema, I will like present that too. And like if it's early, if less than 6 weeks, mostly it's like it can be like related to viral infection, food, drugs. So also like viral infections can cause urticaria, which should keep mind that. And if you see it more than 6 weeks, there is some like immunologic components going on, like autoimmune components can cause that. And like sometimes thyroid disease can cause similar symptoms. And like sometimes and allergies can be caused from like lots of like things. These are the most common ones, like beets, eggs, and milk, so seafood and peanuts. Like there's a mnemonic for VAMPs, for like wheat, eggs, milk, and peanut and seafood. For like egg allergy, like people, this is the one of the most common questions. Can eat like baked like foods? Yes, like most of them can tolerate like baked milk or baked egg very well. Like 70-80% can tolerate very well, because it destroys the like main cause of the allergy. There are like other like non-IgE related reactions and other oral allergy syndromes. I will not like I will not dive the details, but we have like we should keep in mind that like food protein induced enterocolitis, like this is one of the most common in pediatrics. Also like eosinophilic esophagitis is a very vague disease, but if we don't know the like reason on like this heartburn sensation, we should keep in like differential. And latex and insect allergies, like these also like allergic diseases. I will keep it short. Adverse drug reactions and IgA mediated allergy and vancomycin flushing syndrome. These are the two different allergies, and they have different mechanism. Like IgA mediated allergy, most common we know is like penicillin allergy. It will cause like urticaria, angioedema. But on vancomycin, flushing syndrome has different mechanism. It will cause like direct mast cell activation, and it's not immune, and it depends to IV infusion rate. So if patient, like for example, when we keep giving vancomycin to patient, it will give too quickly, it will cause like red flushing, and like we see this on floor. Always like we try to reduce the rate, and most of the time like symptoms resolve. So you don't need to stop the vancomycin right away. Severe cutaneous adverse reactions. There is like Tourette syndrome, Stevens-Johnson syndrome, and also lots of medication can trigger them, like sulfonamides, NSAIDs, anticonvulsants. And these are like rare conditions like serum sickness syndrome, also like mastocytosis. These also like another like allergy diseases. For diagnostic testing, like we can use skin prick test, also like serum specific Ig in blood. Skin prick test is like very quick test, and in 50 minutes we will get the results. But important thing is if they using like long acting antihistamines, they should stop 5 days prior to test. And serum specific Ig is more like safe, and it's more like straightforward, but it's more expensive. Thank you.
Okay, so I covered the immunology and primary immunodeficiencies in pediatrics. So I'll kind of do the same thing as he did, kind of give you like a brief overview, and then we'll jump in. So to begin, I kind of divided the difference between innate and adaptive immunity. And I'm sure we've all kind of known like innate is going to be the super fast acting, no immunological memory. It's going to be non-specific. Versus when we're looking at adaptive immunity, it's going to be a slower onset. You need to develop it over time. It's going to be highly specific, and it does have memory. So I kind of broke apart the different key players. So we have our complement, macrophages, natural killer cells, neutrophils, and then we're talking about adaptive immunity. Those are going to be more of our B cells, which transform into plasma cells, which are going to make our antibodies. And then for our cell mediated, we have like our T cells, which are split into CD4 helper and then our CD8 cytotoxic. And then just kind of keep in mind, of course, like there's interplay between the two. So, macrophages are technically part of innate, but then they also play a role in adaptive immunity as antigen presenting cell. And then I kind of went into a little bit more detail about the specific cell types. Just a few kind of little details is like the natural killer cells. So those ones are always going to be kind of in the kill mode. And so in order for those to not induce apoptosis in something, they kind of need that like don't kill signal. So in this case, like if a cell could be a viral cell that like causes downregulation of the MHC class 1 receptors, then the natural killer cell, that's their signal to kill them. Or like a tumor cell sometimes causes the downregulation of MHC class 1. And then like CD4 T cells, those are going to be the ones that recognize the MHC class 2, and the CD8 are going to be recognized in the MHC class 1 receptors. Okay, so kind of connecting the two, like first we need to get a background on, what is the immune system? Who are the key players? What do we need to know? And then try and connect that to, okay, primary immunodeficiencies. Like, how can we use that background to figure out where the defect is at? So I know this is really simplified per se, but we can kind of look at it as like, okay, if someone has encapsulated bacteria, we're going to kind of think to ourselves like, okay, B cells might be the primary defect. If they have more like viruses and fungi, which are more of intracellular infections, that's going to be more of a T cell defect. And then kind of down the road to if they have deep abscesses or like extreme sepsis, we're going to think, okay, they probably have a phagocyte defect. And then kind of the classic complement defect is that terminal complement deficiency, which is going to be like recurrent Neisseria. So like you can look at that chart to kind of work from the bottom up. We can see that the encapsulated bacteria, if we move up, that's going to be kind of your antibody deficiencies. I won't go through all these. So why does it matter? Primary immunodeficiencies, they're more common, and there's like 300 different identified disorders, and there's more likely that will continue to be discovered. And they are often missed. So they present in infancy or childhood, which makes like pediatric recognition super critical, but also too, it's important to recognize like a B cell deficiency where they're making antibodies. They might not present until like 6 months after because they're still using the trial. And like I kind of said, early recognition signs, they do save lives. So just kind of having that high index of suspicion, if there's something weird kind of going on, maybe it's worth looking into if they have a defect in their immune system. So how do they present? We focus a lot on the infections, like, oh, they have bacterial infections, they have viral infections. Yeah, okay, so there's probably a defect with the immune system, but it's also important to recognize the immune system plays a bigger role in autoimmunity, inflammation, malignancy risk. So when I was looking at the review board's book, I don't know what it's called off the top of my head, but it kind of pinpointed, someone might present with leukemia and lymphoma early on, even before they present with some sort of infection. So kind of keeping that in mind, I think, is important. And another thing too for this is kids are always sick. So how do you recognize a primary immunodeficiency in kids and say, oh, that's an actual issue with the immune system versus, oh, it's just a sick kid who constantly is at daycare. So here are some of the guidelines that were there. It's more than 4 ear infections within the year, and then like a failure to thrive, recurrent deep skin or organ abscesses, and kind of that like family history is also important. So you kind of break it down, the categories of immunodeficiencies, mainly phagocyte defects, B cell antibody deficiencies, T cell, and then complement. And as you can see, 65% of the primary immunodeficiencies are B cell defects. So the first one would be B cells, and I'm not going to run through every single one because that would take way too long, and hopefully we'll get at some of it in the Jeopardy game. But kind of some of the main findings, we talked about those recurrent sinopulmonary infections like otitis media, pneumonia, just because of those low immunoglobulins. And they're going to have like lower absent memory B cells. And that's how you can kind of distinguish between these two like different types of disorders is, okay, we look at X-linked A gamma globulinemia. And with that one, we're not going to have any B cells. And also our immunoglobulins are going to be low. But when we're looking at combined or common variable immunodeficiency, we'll still have B cells, but the defect is in the maturation of them. So they can't go beyond that B cell stage. And so we'll still have B cells. They just won't be able to produce adequate antibodies. And then for T cell immunodeficiencies, I feel like the classic one is DeGeorge syndrome. And you use the classic, catch-22. That's going to be cardiac defects. So that's any conotruncal abnormality, which could be a VSD, tetralogy of Fallot, interrupted aortic arch, things like that. And then they have abnormal faces. So they can have a really small chin or the hypertelorism. And then with the thymic hypoplasia, that is where the T cell deficiency comes into play. So they're going to have usually absent T cells and not absent thymus on chest x-ray. They also have the cleft defects, hypocalcemia, because of the parathyroid gland is either hypoplasia or completely absent, and it is a microdeletion on chromosome 12. And then we look at combined B and T cells immunodeficiencies. I realized later on, I put it twice, but I was like, okay, that makes sense because combined immunodeficiencies is super important, the SCID. So with that one, we're going to have complete absence of T cells. And then if we break it up into two different parts, we have adenosine deaminase deficiency. And with that one, usually they break down into like DATP. And so if you don't have the ADA, then I said that wrong, but the DATP builds up, which is toxic to cells, and then they can't go through any DNA replication. So with an ADA deficiency, we're not going to have B cells, we're not going to have T cells. And then on the contrary, the X-linked SCID is going to be an IL-2 deficiency. So with that one, our T cells cannot properly mature. And yes, we'll still have B cells, but without T cells, they kind of need that proper communication in order to make B cells actually work. So you can kind of separate those two, but ultimately the end result is going to be very similar. And I listed some other T cell or B and T cell immunodeficiencies below, but we'll save those for the game maybe. Okay, and then phagocyte disorders. This is going to be bacterial and fungal infections, recurrent skin and respiratory infections, impaired pus formation, because usually our neutrophils are responsible for that. And when we look, I'll use chronic granulomatous disease as an example. So with this one, we have a defect in the NADPH oxidase, which usually is important in making those superoxide radicals. And so that is kind of what they phagocytose the microbe, and then they use those radicals to kill it. Well, the defect is especially important in catalase positive bacteria because normally bacteria can have the hydrogen peroxide and then the phagocyte can, eat it and then kind of can steal the hydrogen peroxide in order to still kill the bacteria. But with catalase positive microbes, they are able to break down their own hydrogen peroxide. So with that microbe, it's like, oh, they don't even have the hydrogen peroxide in order to steal. So some of those examples would be like Aspergillus and Pseudomonas there. And then for testing for the chronic granulomatous disease, we could do the DHR flow cytometry test. And then complement disorders, kind of talked about this one a little bit, but if someone is having recurrent Neisseria meningitis infections, that leads us to thinking, okay, they probably have some defect in their terminal complement, which you remember, you can have classical, lectin, or alternative pathways. And that primary, where they all kind of come together is going to be the MAC complex. So that's like the C5 through C9. And then it creates the hole in the microbe in order to kill them. So because Neisseria meningitis has a capsule, that makes it extremely susceptible because a regular phagocyte can't kill it. You kind of need that membrane attack complex. And for that one, complement deficiencies, you can do the CH50 test to kind of see. And if you have any deficiency in any of the complements, C3, C4, wherever, it will show, it will come up as irregular. And lastly, just kind of some diagnostic tests for immunodeficiencies. What do you do if you suspect some primary immunodeficiencies? Well, if you were thinking like B cells are the issue with those cytopulmonary infections, you could do quantitative antibody tests, or you could do a flow cytometry because CD19 is the marker for B cells. For T cells, we're looking at that flow cytometry, except the markers are a little bit different, the CD3, CD4, CD8, and then also kind of on the right, listed some functional tests you could also look at too. For phagocyte disorders, you can do that neutrophil oxidation, which with chronic granulomatous disease, that would show up as irregular. And then complement deficiencies, that CH50 was talked about a lot. And if they have any defect in any of the areas of the complement, then it's going to come up as irregular. Okay, that is what I had for the immunology. And then we will move into the Jeopardy game.
We will teach you guys with like game. We have like right now 2 groups, but we can make 3 because the last line is very long. Go there. Or we can have all groups. Oh, yeah. Yeah. Greetings. So we're gonna go first. So I'll start with new chiefs. Ahmed, choose topic.
I need to determine what you go by. This is the third. Okay, I'm in. I'm in the same. So
I can do 3 groups, that's fine.
we're gonna Immunodeficiency was 500.
Yeah.
500.
Go big or go home, I guess.
Okay, otherwise asymptomatic patient who develops anaphylaxis following a blood transfusion.
Can any of us hit the button?
Yeah.
Oh, hit the button, see ya.
You are not told. You're very.
Like we need to finish the question. After that, you need to press. If you guys press it, like before we finish the question, we will not count. And if you guys give like wrong answer, there's no. Okay. Okay, then we'll read the question again.
So it's IgA deficiency.
Okay.
Okay, yep, that's.
What?
I didn't say what it is. We don't know that rule.
So my oh, you guys go ahead. Sorry, I wanted to say.
Oh, that's okay.
My only commentary on this is that selective IgA deficiency is about 1 in 500 people. That's really common. I mean, that's really, really common. So if we were screening everybody beforehand, you would be seeing a lot of anaphylaxis with blood transfusions. So this is a question that comes up on the board and you should absolutely know it. But in practice, when I diagnose someone with IgA deficiency, I don't actually recommend any like screening before they get a blood transfusion or something like that. Because the truth is that would probably be more harm than good. Presumably, if you need a blood transfusion, you kind of need it then. So I think this is one of those clinical versus book type questions. Good to know. Don't worry about it too much. Unless it's somebody who's already had anaphylaxis and has IgA deficiency, you know they have some kind of thing like that. Yes, then the blood bank can do stuff to the blood to help us out.
Okay, well, that was correct. But we kind of hit on it. So people with IgA deficiency, they can develop IgA antibodies. So then when they get that transfusion, those antibodies kind of attack the red blood cells. But it's right. And do I click home?
Home, yeah.
Okay. Oh, that was not
It's
home.
good. No.
That was too much.
You just sit back.
Oh, we'll take this. Okay. Because we can.
Allergic reaction 500.
Okay, allergic reaction 500. So 40 years old girl began taking minocycline for acne. 4 weeks later, she presents with high fever, facial swelling, diffuse lymphadenopathy, and widespread skin rash. Laboratory test shows.
You should.
It's done.
Testing shows significant peripheral eosinophilia and elevated serum transaminases.
No.
You guys will.
I read that, like I can read it.
I need the pins. No. So other than Ahmed's group, who gonna answer? Okay.
It doesn't matter if you do it 10 times. No, we can say. Yeah.
Okay, hold on. Wait.
Is it serum sickness?
No, we're
No,
next.
no,
We're
we're
next.
next. We're next. Come on, Sean.
Disqualified, bro.
Yeah,
have to moderate.
What is drug reaction with eosinophilia?
great.
Dr. White and I will moderate. The button pressing.
So what is Rett syndrome? Yeah, drug reaction with eosinophilia and systemic symptoms. By the way, great. Like I can't hold. It's a severe type 4 hypersensitive reaction mediated by T cells, and it's distinguished by like long latency. So patient will take medication maybe like 4 weeks before, and they will have this reaction. So we always keep in mind that like we always ask like, what did you take recently? But also we should ask like if it's like, what did you start like last month or something? So it's important to differentiate that. And I like prepare small like infographic here. It says like it shows like loss of medication can cause that, like minocycline, one of them, anthracyclines can cause, epileptic medications cause that, antifungals can cause that, and it's caused like flushing and like some like organomegaly and lymphadenopathy.
Can the patient take the medication again? Like,
No, so once you have a severe cutaneous adverse drug reaction, a scar, there's no, well, we could talk about experimental testing, but there's no real testing to do, and they have to avoid that drug. It is usually specific to that drug. It doesn't take out the entire class, for instance, of antibiotics or the entire class of drugs. But you still tend to try any new ones in that class of drugs with some caution.
what about if it's like a serum sickness-like reaction, but not serum, even then you don't.
Serum sickness-like reactions, I recommend actively trying to reintroduce those ones, especially in peds when it's, amoxicillin or something very important like that. The SSLRs, absolutely. I say let things calm down for a year or two and try it again and it'll probably go fine. And serum sickness-like reactions also have a pretty long latency period. One little thing, because DRESS, really severe reactions, right? There's something you should think about a lot more than you're ever going to see them. So this is a severe thing you would want to know about. If you're ever thinking about it on the wards, Regiscar, so it's Regia and then registration and then SCAR. That's a good stratification tool. This should tell you yeah, that maybe could sound like DRESS, or no, that's not really, that's 1 point, 2 points, doesn't matter.
Oh, the other one, Keith.
Yeah.
We were gonna write on this board. For you guys. Don't come back. All right. Who won it?
Yeah, Anish. Team Blue. Yeah, Team Blue. 500.
Which one are you
Well,
doing?
let's wait for it. Yeah.
Amen. The color of your buzzer. It's yellow. Yellow. Okay. And yeah, Anish group take 500. What is next?
Well, we have to see.
Yeah.
Immunodeficiency is 500.
No,
It's gone.
Yeah, I think that one's taken.
Immunodeficiency gone.
You can do immune mechanisms 500.
And prevention. Immune or prevention 500, or you guys can go 400.
No, immune mechanisms first.
Okay.
Recurrent meningococcal meningitis in an otherwise healthy adolescent with no history of respiratory infection.
Oh, it was yellow.
I kept reading.
I was looking at her face.
They got it.
Okay. What's your answer?
So it's terminal complement deficiency.
Yeah. Okay, so I feel like I talked about this a lot. If they have recurrent meningitis, then we're kind of looking towards that terminal complement deficiency there because they make that membrane attack complex. So with this, if you do discover this deficiency, they're going to need, of course, the vaccination and long-term prevention strategies. Did we figure out how to do
Yes.
this?
No. You need to go back all the way. So
What is the efficacy of vaccination when you have a complement deficiency like that?
It is limited, but still some.
Some.
And you tend to keep people on prophylactic antibiotics too, especially if they've had multiple bouts of something.
Is there a time period when you would put them on prophylactic antibiotics? Like if they're in college or in school, and then when they're in adulthood, you stop? You just always have them on it.
I know it goes against everything you learned about antibiotics, but in the immunology world, we put people on prophylactic antibiotics indefinitely because we're not worried about resistance. We're worried about the fact that we know that their immune system does not work against that bug. We know that it doesn't, so you just keep them on it.
Okay, thanks.
So prevention, testing, and therapy for 500.
okay. A 16 years old boy with a history of severe honeybee sting allergy is brought to the emergency department after being stung. He's currently taking propranolol for migraines. On arrival, he has anaphylaxis symptoms and patient took first-line treatment, but his symptoms don't improve. What alternative medication should be administered to bypass this interference? It's hard. Okay.
Okay, green.
Glucagon?
Correct.
Oh.
Yeah, patient taking like beta blocker and it's interfere due to like epinephrine work on like both alpha and beta receptors. So the effects of epinephrine are blunted in patients taking beta blockers, which is why these medications are relatively contraindicated in patients at high risk for anaphylaxis. And if they have like any like allergic reactions, so we should go to like another medications for migraine or like hypertension. When a patient in anaphylaxis doesn't respond to epinephrine due to beta blockade, they should get glucagon first to bypass this adrenergic blockage.
Hard question. Good job.
In my world, this actually comes up a lot. But for a lot of people, this is just a board question, but it is one that shows up on boards all the time.
I think all the 500s are gone.
Yes.
Yes.
Immunodeficiency 400.
A young boy presents with eczema, recurrent infections, and thrombocytopenia with small platelets.
Ooh, green. Or wait, what color is Trish's? Oh, sorry, can't see the button.
It's not a recurrent infection. WAD syndrome.
Yeah, what is Wiskott-Aldrich syndrome? So this is an X-linked immunodeficiency caused by mutations in the WAS protein, leading to combined T and B cell dysfunction. So I kind of remember it as water, like WA, and then thrombocytopenia, eczema, and then recurrent infections. So you get abnormal bleeding in infancy. And then for that one too, you could do the hematopoietic stem cell transplantation for treatment.
Good mnemonic.
First aid.
400 for immune mechanisms.
Not clicking. Okay, well.
Sorry, that one's not an option. Cancel allergic reactions for 400.
There you go.
6-year-old boy is prescribed cefaclor for an ear infection. 7 days into the treatment, he develops a fever, joint pain in his knees and ankles, and itchy red rash that persists in same locations for several days. He never take this medication before that.
Oh, Dr. White, you get to decide.
I'm gonna go with the front row.
What is serum sickness?
Yes.
Anyone read the older?
Yeah. It was actually really helpful for me. And then it was actually like, who was.
Serum sickness-like reactions are most commonly caused by cephalosporin groups and penicillin-based other drugs. And unlike classic IgE-mediated allergies, they don't require prior sensitization. So if patients take the first time, they can have it. Like for other allergic reactions, like generally they like have prior exposure and they don't have reaction. Generally, allergy happens on second exposure, but serum sickness is different.
Also a terrible medication for ear infection, but there you go.
They should have their penicillin allergy delabeled so they can get past all the
Yes.
next stuff.
Immune mechanisms 400.
I think we read that one.
Oh, okay.
That's the one that doesn't work, sorry.
That's chemotherapy. 400.
8-year-old boy with chronic allergic rhinitis is referred to the York clinic for skin prick testing to identify triggers. He took his usually daily short-acting antihistamine this morning. To ensure the test results are valid and to avoid the protective reaction, these amount of days must the patient wait after his last dose.
5 days. Wait.
Wrong.
To ensure that.
Oh, no way, no way. That's my answer.
I emphasize the short, not long. On presentation, I asked the long. This is short.
Wait.
So I tricked you guys.
Oh, you are tricky and sneaky.
They already answered. They said 5 days.
They lost the F.
Yeah.
What is so? Yes.
No.
That was in the presentation though, but long acting.
Then a forum, this is a
We have someone. Yes, yeah, you can guess.
72 hours.
What? We have another guess. Close but not.
Oh,
24 hours. No. Okay.
oh.
So in presentation I said for long acting is like we need to wait 5 days. But if they are taking short acting, they should wait 48 hours.
Dr. Kavis cannot be on the board. Question writing. Okay.
We're talking about like Benadryl. Benadryl's, 3 to 6 hours. That one you wait 2. Zyrtec, hydroxyzine, you wait 5 for those. But I will say officially, a lot of allergy clinics tell patients 10 days just to make sure that they've actually been off 4 or 5 days. So if you hear different things like that, that has to do with health behavior and getting people to follow directions. But officially, it's 2 days and 5.
Oh, no.
So Chris, you choose.
300 for immunodeficiencies.
Okay, 300 for immunodeficiencies.
Pilotrunchus arteriosus, hypocalcemia, and recurrent viral and fungal infections.
More infections.
End of the question, but Trudy's team got it.
Yeah, well, wait, what? She said infections a little later, so I pressed that.
Yes, she
Hey,
did.
Josh. What is the Josh?
Yeah, so
This is not.
I mentioned this. I did prolong it a little bit. Yeah, so this is a George catch me to phonotruncal abnormalities and low calcium. So you could look for like any tetany, seizures, anything that shows low calcium.
So the George syndrome is something that you might see very well in the NICU. Like you look for those spaces, and when things aren't going right, when their calcium is low and you can't get it up, this definitely comes up, and you can get like genetic screening for it pretty fast. The problem is not initially with the immune system; it's just the midline deformities, and that's where your thymus is, and that's where the T cells have to come from. So that's why it's nice. It's kind of in a syndrome, at least, where there's other things that can clue you to what's going on. And sometimes you can certainly have partial DiGeorge. Like maybe you have like more of the lower midline defects and primarily immune stuff, but your calcium's fine. You don't have cleft palate. Sometimes you have more of the upper midline defects and your immune system's fine.
So if you diagnose someone with DiGeorge, what is kind of your first step that you tell them to do, or how you point them in the right direction?
Well, in the course of diagnosis, you're getting lymphocyte flow cytometry. You're getting an idea of how bad their immune defects are. And if the immune defects are very severe, then you're talking about prophylactic antibiotics. You're doing vaccine responses to see if they're going to need IVIG long term. Best case scenario in like immunology centers, there's these multi-specialty clinics where you have ENT and craniofacial surgery there to look at the mouth. At the same time, the endocrinology is paying attention to their thyroid, their parathyroid. And then immunology is there too to decide just how much. But it's not a one and done thing. It depends on how severe their immunodeficiency is as to what you actually do.
Okay, who got that? Okay.
How are we navigating into the?
Then I
So we gotta talk about this thymic transplantation. It's like how common
Yeah.
actually is that?
Almost not common
Yeah.
at all. Like there's a few very experimental places that do it, but it's really not.
Actually bad.
I knew a kid that was on the waiting list for like 5 years. I mean, at that point, it's like,
Yeah, it's not unfortunate. Oh, sorry. Viruses, fungi, and protozoal infections, chronic diarrhea, failure to thrive, and an absent thymic shadow on chest radiograph.
shrewd.
which one? Chin.
Green?
Yeah.
Whoops. Yeah, so this is SCID. It's a group of inherited disorders characterized by profound defects in T cell development and function, resulting in impaired cell mediated and secondary B cell dysfunction. So kind of that chronic diarrhea, failure to thrive, severe infections, and the absent thymic shadow on chest radiograph is diagnostic for that. And there's a lot of talk about newborn screening with that through the T-Rex is really important. And you maybe could talk a little bit, I don't know a whole lot about that area.
You might have more flashbacks to this having just taken step 1
Yeah.
than some of us here. But it's actually pronounced Trex. It should be pronounced T-Rex. That's a way cooler name. But people say Trex. Those are T cell receptor excision circles. So when you're making your T cell receptors, when you're making antibodies and B cell receptors, do you remember that genetic material is kind of cut out in order to make a bunch of random, and they're not entirely random, right? It goes through some testing in the thymus to make sure that you're not making autoimmune T cell receptors. But that genetic material forms these little circles. If you're not making T cell receptors, then you won't have those Trex in your blood. And so newborn screening has helped with diagnosis a lot with SCID, but it's not 100% because people will miss their newborn screen. You're meant to have 2, and if you don't like get that second one, for instance. And then there's other things though that can give you false positives, even like gestational diabetes, that can influence the T cell development in an infant. And so you might see low Trex for other reasons, but it's a really good screen, and it has actually only been nationwide, I think, since 2010. So it's like not that old of a system, but it has led to a much earlier diagnosis. And as soon as you have an abnormal Trex, then you send a lymphocyte flow to see, okay, well, how many T cells do they have? And B cells and NK cells. And then, if it's low, then you start taking a lot of precautions.
Do you guys want immune mechanism 400?
Recurrent skin and organ abscesses caused by Staph aureus and Serratia maritensis, and a child with normal neutrophil counts.
What is chronic granulomatous?
You're possible.
There's a defect in the respiratory oxidative burst, and 2 microbes were catalase positive, which is most likely going to be the bacteria that they present with. They present with the recurrent skin and perirectal infections, liver abscesses, and osteomyelitis. Diagnosis is made with that DHR flow cytometry. And most cases are going to be X-linked, but there were a few autosomal recessive forms. So most likely going to be a male, but might not be. Sorry, I'll let you do that.
Which of, have we done all the 300s or no?
I believe we didn't do prevention.
Prevention.
Prevention?
Okay, prevention, testing and therapy for 300.
7 years old patient with moderate to severe persistent asthma is transitioning to treatment regimen known as SMART therapy. This approach allows the child to use a single inhaler for both daily maintenance and quick as needs relief of symptoms. What are the two classes of medication contained in this combined inhaler and
Was it us?
yes.
Okay, what is inhaled corticosteroid and a SABA?
Yes.
No.
But no. This is Sava. Did you say Sava? No.
Oh, she said short acting.
Excuse me, she said.
I heard like a lava.
It is lava. She said lava.
Fine, the team said lava.
I'll count it and you can be on the race. So also we know as Symbicort like contains like two medications in one, inhaled corticosteroids and formoterol. And yeah. That's it. Good job.
All of the studies have been done with budesonide formoterol, which is either Brena or Symbicort. But truthfully, like you could probably do it with Dulera, which is mometasone. The important part is the formoterol, because formoterol is a long-acting beta agonist, but it has a short onset of action. As opposed to salmeterol is a long-acting beta agonist, but it also has a really long onset of action. So if you were trying to use it right when you need relief, you wouldn't get any relief. Formoterol is only a little bit longer to act than albuterol, which is why it kind of can work that way.
It's also why if you, so due to Dr. Wallace's testimony on the South Dakota Medicaid P&T committee, formoterol is the only one covered by Medicaid, South Dakota Medicaid, for your combination there.
Yeah, great.
Hey, what did you pick?
Immunodeficiencies for 200.
Recurrent sinusitis and pneumonia beginning in adolescence with low IgG and IgA, normal B cell counts, and poor vaccine responses.
Hypogammaglobulinemia. What is that?
Something more specific.
Yeah.
Which?
A common like
Okay, basic version.
a specific. Okay, go ahead.
Glutons, what is glutons?
No, we got it. It's the combined variable immunodeficiency. Yeah, like we have to get extra points.
So it's a common variable immunodeficiency. Yeah, I knew what you meant. Okay, so with this, the key here was the normal B cell counts. So with the X-linked, the glutens, can't never say that, gamma-globulinemia or whatever, you would have low B cell counts. So that's where kind of that key detail came into play here.
And XLA would present from birth. Like they would have issues in their first or second or third month of life. And the patient here was fine until adolescence. And so that's kind of a thing with CVID is really you don't diagnose it much until you get a little older.
Oh, allergic reactions for 200.
Okay. While skin findings occur in like up to 90% of anaphylaxis cases, this specific diagnostic criteria allows for a diagnosis even in the absence of the skin or mucosal involvement.
Hypertension.
Yes.
What is hypertension?
Yeah, we have a short time, so I will not read the like explanation.
Yes.
Okay, next.
Yeah. He's ready to answer all.
Okay, this is a tiebreaker for the top two teams, and then we'll be done.
Okay.
Although you,
come from behind.
What's up for 200 prevention testing?
Yeah.
We can go for that. 5-month-old infant with severe atopic dermatitis and non-egg allergy is brought to your clinic for wellness visit. The parents are concerned about the further food allergies and ask for your recommendation regarding the introduction of peanut-containing products. What is the recommended age range for introduction in this high-risk infant, and what is the required clinical step before the first home exposure?
4 months old.
Yes,
And
what is the clinical step before?
What's clinical step? We took hands avoid.
I'll answer really quick. Okay. So what is the 4 to 6 months? And like we need to do allergy testing. So like for high risk population, like with like severe eczema, egg allergy, or other symptoms, we need to do allergy testing first. That we can introduce that on clinic settings, like on healthcare provider supervision between 4 to 6 months of age.
I just want to say really quick that this should not be on your boards because it's so controversial. Technically, the guidelines do say that you should do a skin prick test before you introduce it. I know that a baby can always get in with me really fast, but in practical terms, getting to an allergist, especially like, farther out in the state, getting to see an allergist, what if they don't get to see me until they're 9 months of age? Then they might really actually be peanut allergic. So in reality, it's between 4 to 6 months of age, you should try to introduce it anyways. Yes, they are at higher risk for peanut allergy, but if you wait until you get that skin prick test or you wait till you get that IgE, and even if the IgE, because IgEs are highly, highly sensitive, which is not always clinically relevant. You get that IgE, it's positive, and then they wait forever. That's the time frame in which the immune system does coordinate into true allergy. You can have sensitization before you're truly allergic. So if this baby came into my office, I would just feed them peanut butter right then and there and be done with it.
Are you hungry? Good.
All right, thank you,